I had the opportunity at this year's ASH 2022 to present abstract 377. This is a phase 1 clinical trial that was performed at Dana-Farber Cancer Institute that looked at the safety of prophylactic Azacitidine and Venetoclax given in combination at lower doses for patients that undergo a reduced intensity conditioning transplantation. The patients in this study had high-risk MDS, AML, or MDS-MPN overlap syndrome. So here I had presented some data where I reviewed some of the background we had previously shown and published in Blood Advances. The first 22 patients where we had added Venetoclax to Fludarabine, Busulfan, or FluBu2. That's our institution's reduced intensity conditioning backbone. What we had been recognizing with FluBu2 alone is that our patients with MDS or AML, particularly those with persistent MRD or measurable residual disease, or for those that had high-risk mutations, we knew that they were at higher risk for disease relapse post-transplant. And unfortunately, post-transplant disease relapse has a poor outcome overall. So we were hoping we could try to optimize conditioning chemotherapy. And we've previously published on the safety of adding Venetoclax, an oral BCL2 inhibitor, to FluBu2. And what we demonstrated was no issues with engraftment, no infectious complications, no serious cytopenias, and importantly, no tumor lysis syndrome. As some of the patients still went on to relapse, we then asked the question, based on some of the data we had started evaluating that looked at measurable residual disease in terms of genetic MRD, we saw that there was a potential therapeutic opportunity time point somewhere by day 100 where we'd like to intervene. So we offered an amendment to the clinical trial where we added on a separate cohort where patients received Venetoclax plus FluBu2 for conditioning because we found it to be safe. And then we gave everyone that was on trial that made it to maintenance therapy, prophylactic Azacitidine and Venetoclax with the goal of preventing genetic MRD expansion and ultimately disease relapse. So this abstract was all about presenting the safety and the early efficacy data. So what we were able to demonstrate is among 27 patients, 22 were able to receive maintenance therapy. Among the 5 that did not, a couple had withdrawn because they didn't want to get more treatment, and then 3 had gone on to relapse before we could even give them maintenance. So 22 were able to receive Azacitidine at 36 mg per meter squared days 1 through 5, plus Venetoclax 400 milligrams days 1 through 14. We tested 2 dose levels. It was really the same dose, but on different schedules. One was every 42 days, and the other was every 28 days. And our question was, is it safe? Is it toxic? Are there infections? What we were able to demonstrate is, one, most of the side effects were GI that were only grade 1 and reversible with antiemetics. We found that 2, the most common AEs were hematologic, but the majority were not serious. There were 19 out of 27 patients that had grade 4 neutropenia, but it was transient and expected. What we looked at was when patients were able to move on to the next cycle, and it was required that patients had recovered their counts, and pretty much the majority of patients, and not all, but the majority were able to start on time. So there was not a huge difference or concern for delays in cycles due to neutropenia or thrombocytopenia. We also were able to start maintenance therapy at a median of 57 days post-transplant, which allowed patients some time for early engraftment. I think that was part of the reason why we were able to successfully start treatment. We required a certain neutrophil count and platelet count before the maintenance therapy could be started. So we not only demonstrated safety, we found that the GvHD rate was very low, and we also saw that the early outcome data was very encouraging. We saw that among patients that received therapy, the overall survival and progression-free survival mimicked what we saw with patients in cohort 1 that we previously published where they did not receive planned maintenance therapy. When we took a look at patients that did receive maintenance, so this is some selection bias, among the 22 that actually got Azacitidine Venetoclax, the 1-year overall survival was 82%. And we think that's pretty robust, especially because the population is quite sick. They have bad risk mutations. So we're in the process of doing some deep sequencing to understand who are the patients that can clear disease, and does that mean they're going to have a better clinical outcome. And we're also taking a look at yet a 3rd cohort that looks at an all-oral maintenance regimen with decitabine, sidazirine plus Venetoclax.